for internal and external rotation of the hip. Go ahead and grab with your hand on the front edge of the table. A couple of ways you can position yourself relative to the patient. One way you can do it is to actually face the patient. If you're going to do internal hip rotation, you need to put the hip first in the externally rotated position, which means right here. Now I'm going to anchor here. Sometimes that hip wants to abduct and/or flex while they're doing this movement. The movement's going to go from here to here. You're not going to be able to palpate your gluteus medius fibers, so you're just going to have to guess whether or not they keep the muscle turned on at the end.
Can you do that again?
Oh, I haven't finished it yet.
Okay.
Okay. You're not going to be able to palpate these muscles. Okay. So to do internal rotation, you start in the externally rotated position, and the movement's going to be out like this. Okay? I'm resisting on the lateral aspect of the leg, proximal to the ankle. Okay. Now, to externally rotate the hip, we want to start in the internally rotated position. So we're going to go out here and go the other way. Now, I said that one way to position yourself is this way. You can position yourself this way if you feel like you get a better, you're better able to resist the movement. And if you're going to get on this side, then what you'd be doing, you'd get on this side to do internal rotation, the other side to do external rotation. So, if you're on this side, you're getting that your forearm lined up with the direction that the movement's going. Okay, again. Okay. And then you can go on this side.
So that was internal and then external.
Mm-hmm.
Okay.
I'm more comfortable just facing the person. That's just the way I've done it for eons. But you may get somebody who's muscular, so much stronger than your ability to resist. You might want to get over here, and it will be easier to resist. It may be a little cumbersome getting this anchor here, but slide down. If you put them on the end of the, if you're going to get on the side, and you put them on the end of the table, then you do it like this. Then you're in good shape. And then if I work this leg on the other side, I can slide them down that end of the table. Okay, what next?
Abduction and adduction.
Abduction and adduction. Okay, on your left side, back up again. Okay, abduction, flex that lower leg back. Okay, and grab the edge of the table. Okay, I'm going to try to get, I'm trying to get everything lined up like this. Okay. There's going to be a real hard tendency in most people to flex at the same time they abduct. You don't want them to flex because that takes them out of what plane of movement?
Frontal.
The frontal plane movement. Sagittal axis frontal plane movement. And when you let that femur go out of the frontal plane, then you get a little bit of misalignment with respect to the optimal position for abduction. The flexed leg here and the hand here helps keep that frontal plane perpendicular to the table. Okay? If you're going to apply any resistance, which may not really be necessary because this leg is so heavy, go ahead and apply it here. Keep your fingers wrapped over so in case they flex, you can keep them pulled into the frontal plane. Okay, come on up. And then you can stretch the end again. Now straighten your lower leg, and we'll do adduction. I'm going to support the leg here. Now bring your other leg up to the top. There you go. You got stronger adductors than who was doing this the other day.
That's Howard.
Howard, yeah. Okay, good job. Okay, now turn supine, please. That's a pretty cumbersome way to do it. But if they come in you with pretty strong abductors, you may want to go ahead and do that. They may not be very strong, and it could be that the only resistance they can tolerate is the resistance that the table provides by the friction on the table. And so if you're going to do abduction, you'll passively put them in the adducted position and just spread your legs apart. Okay, then I'll bring them back, spread them apart again. I'll bring them back. Now, the reason I'm bringing them back is that if your prescription calls for adduction, there is a chance that you're trying to stretch out the adductors, and so you don't want to let them bring them back in. Okay, now for if you're going to provide, you can provide some manual resistance in this position. If you do that, you want to give a little bit of flexion in the knee. This is going to put the lateral collateral ligament on a little slack and force the iliotibial band to take the brunt of the force. Resist proximal to the ankle here and push out. Again. Now, if you want to be lazy or use your ingenuity, just take some TheraBand, tie it around here above the knees. Just let them go work against that. Okay, adduction. I'll start them here. Get a little knee flexion. Okay, now push together. You can do. You're just going to sit up. You can do some isometric adduction if they're weak enough that they can't just do any isotonic movement. Maybe they can sit here and mash their knees together against your fists. But in terms of the manual resistance routines that you would apply, those are some ways you can do abduction and abduction. What's another?
To the knee, we have extension and flexion.
Okay. Extension, flexion in the knee. We're going to put our pad in place just like we did for internal and external hip rotation. Okay, go ahead and grab your. Now, I told me grab the front of the table. There may be a reason why you would want them to lean back on their hands. What would be a reason for having them lean back? What would be a reason for having them grab the front of the table?
I think it has to do with lifting the hamstrings, we are holding on to the front of the table, like it.
Okay, come on, keep talking.
Lifted in the hybrid centers.
Okay, yep, that's correct. Both of those are correct. If you're leaning back, you're going to get more involved in the rectus femoris. It's going to be, you're also going to get less stretch on the hamstrings. If you grab them forward, you're going to get a little less work on the rectus femoris as an agonist, but a little bit more work on the vastine muscles. But it's going to be easier to stretch the hamstrings. So let's suppose that you don't have a particular reason to stretch the hamstrings. But you want to isolate the rectus femoris to strengthen it for whatever reason, then you can go like this. Just do knee extension this way. if you want to maximally strengthen all 4 quadriceps, and you want to do do your sets in this position to focus on the rectus, then you want to do some sets in this direction to focus on the vasti muscles. Okay. We'll just do the hands up forward for our demonstration. Okay. Anchor here, keep that knee from coming up, and also to palpate the quads so that you know that it's appropriate to add a stretch at the end. Resist on the anterior side, proximal to the ankle. Push it back into a little bit of flexion, and now extend. And I'll stretch at the end. Okay. Knee flexion. Prone, please. Okay, come this way a little bit. There you go. Okay, knee flexion. Anchor here. You can resist like this or resist like this, whatever way you feel most comfortable. And the movement's going to go all the way here. Okay. Again. Yeah, he's fighting me. I mean, that's how you create an overload. I'm trying to keep him from flexing while he's trying to flex. Okay, so that's knee flexion again. Palpate the hamstrings to make sure that they're still turned on when you add a little stretch at the end. Okay, the next one.
Internal and external rotation of the knee.
Okay. Just roll up on your right side. And flex your lower leg back, lower knee back rather. Okay, hand your knee back. There you go. It's good, not too far, so you don't flop off. Okay, you want that knee at 90 degrees, because then that's at 90 degrees, the hamstrings work like the reins on a horse with respect to the tibial movement. The 2 medial hamstrings help to internally rotate. The lateral hamstring helps to externally rotate. So here are the medial hamstrings on the top or on the bottom?
Top.
They're on the top. Okay. So for internal rotation, which is movement from here to here, here to here, those are the hamstrings that are going to be working. So I'm going to palpate with my thumb on the tendons of the medial hamstrings and with these fingers on the tendon of the biceps femoris. And what and if he can tighten up the medial hamstrings but keep the biceps femoris relaxed, then I know he's doing this movement properly. So I'm going to grab at the ankle, externally rotate, now internally rotate. Come on. Need a little bit more practice. Go. Again. Again. There we go. There you go. There you're getting it again. Okay. So when you're doing medial rotation or internal rotation, the leg that you're working on needs to be on bottom. Okay. Now, rather than have him flop over in the other direction to show you lateral rotation or external rotation on the same leg, I'm just going to let him stay there, and we're going to work on the top one. So straight, and try to get this. You got another pad around here? I'm going to try to get this tibia as close to parallel before as we can. 90 degrees here. So now the movement's going to be from here to here. Here. I can already tell he's a better external rotator than he is an internal rotator. Okay, now the agonist is going to be on top, biceps femoris. The antagonist, medial hamstrings, on the bottom. So palpate here, lift down and palpate here. So I'm externally rotating now. I'm internally rotating, so now you externally rotate. Oh, great. Much better external rotator. Okay, so that's external or outward or lateral rotation of the knee. Okay, what else can I show you?
Plantar flexion and dorsiflexion of the ankle.
Okay, let's do dorsiflexion first. I want you to sit up and extend your feet over the end of this table. Okay, dorsiflexion. I'll show you with the knees extended first. And I like for them to sit up so that they can get feedback by seeing both the belly of the muscle swell up when they contract the muscle and the movement of the ankle as it goes through dorsiflexion, so that the brain can connect those two. Sometimes when a person has had some type of brain injury, we may have to help them reconnect that this contracts when this moves. Okay, so anchor here, right over the tibialis anterior. Resist on the dorsum of the foot, and the movement's going to go all the way like this. And I'll get some stretch at the end. Go. Good. That's the way to keep that agonist activated. There you go. So that's dorsiflexion with the knee extended. When you do that, you're going to get the primary stretch going to which muscle?
Yes, sir.
The gastrocnemius, because gastrocnemius is a knee flexor, so you get the knee extended, that lengthens it as much as you can. When you want to stretch the soleus, just have them slide over the edge of the table. Now, you're still going to do dorsiflexion, but because the knee is flexed now, you're not going to get near as much stretch on the gastrocnemius. It's going to move down here and stretch on the soleus. So you can anchor here, resist on the dorsum of the foot, pull it up. Can you tell that the stretch is moving a little bit lower in that leg?
Yeah.
Okay. Okay. So if you're doing dorsiflexion to stretch the soleus, knees flexed. Doing dorsiflexion to stretch the gastrocnemius, knees extended. If both plantar flexors need to be stretched, do sets in each position. Okay, turn prone and let your feet hang over the edge. Okay, we want to do plantar flexion in the knee extended position if we want to maximize the involvement of the gastrocnemius as the agonist. So anchor here, resist just proximal to the MTP joints. Okay, now push, and then I stretch at the end, again. Okay. So that's plantar flexion with the purpose of maximizing the work done by the gastrocnemius because the knee is straight. Okay. Now, if we flex the knee, come over this side. We flex the knee. Now we're putting the gastrocnemius on slack, which doesn't mean that it's not going to work. It's just not going to be as effective of a contractor or as effective an agonist. So that forces the soleus to come in a little bit more forcefully. So we push here, and I'll stretch like that. Okay. What else can I show you?
Should we do inversion or eversion?
Sure, yeah. I'm going to introduce that on Monday, but I can show it right now.
Yeah.
So I want you to take your socks off for this one. It's absolutely essential that they be barefooted when you do this. So lie on your side and extend your lower leg over the end of the table. Okay, and y'all gonna need to come over here and look at this, because I want you to see the tendons that are popping out. Okay. To do Okay, now which are we gonna do inversion or eversion with this position?
Inversion.
Inversion,
because
because
of
that's
gravity.
working against gravity. Okay. We want this to be 90 degrees to this, okay? Now the movement, you're gonna grab here around the calcaneus, around the forefoot, and show them the movement, which is from here to here. Some of them are wanting to plantar flex. Don't let them plantar flex. Here to here. Okay? Do your movement. Okay. Relax. Okay. Now when you get to the top, we're going to hold it. Okay. That tendon, tibialis posterior. This tendon, tibialis anterior. Both of those have to pop out if it's true inversion. If you don't see both of them, it's not true inversion. Okay. Relax. Let's go again. There you go. Again. Okay. Questions on inversion? Okay, let's just flip over here. Let me go to the towel. Yeah, I'll take that too. Try to get the leg parallel to the floor. Okay, still want this perpendicular to this, so we'll start here. Movements from here to here. Okay. Okay. Now, which of these are you going to do if you have someone that habitually sprains the ankle in the most common direction of an ankle sprain?
Inversion.
You going to do what?
Inversion.
You going to do
No,
no.
eversion.
You're going to do. You're going to. You're going to prescribe inversion. I'm sorry. You're going to prescribe eversion because it's typically an eversion
Inversion.
sprain.
Mhm.
So because when we sprain the ankle, most likely we go like this because we invert that ankle or the subtalar joint. So that means the muscles out here are likely too weak. So we're going to prescribe eversion to strengthen the outside of the ankle. Because this is how most of the time we sprain our ankle. Okay.
Is there anything else that you're going to give us on Monday?
I think those